We'll go ahead and get started. We'll read the question and then we'll kind of pass around the microphone and answer them. So this question is, please tell me what is the best schedule to take carbidopa levodopa? I have been told every 5 hours with food. Do not eat until after the pill, do not eat before the pill, and so how do I answer that? And so a few ways to answer that question. One is that there's not a best schedule that's the best schedule for everybody. Each person with Parkinson's is unique. It depends how long you've had Parkinson's and what symptoms you're having. We may start with 1 pill 3 times a day, and it will gradually increase in how much is needed per dose and how many doses per day based on each person's experience. The question about the food, though, is a little bit easier to answer. So it is true that when you eat protein in your belly, it can compete with levodopa to be absorbed. That means if you take it with food, you may not get quite as much out of each dose. Now, for many people, particularly if you have mild Parkinson's, you may be able to take it with food and not experience that being an issue for you. So in early Parkinson's, I even will tell people to take it with their meals so they can remember it and it can be convenient. However, if you've had Parkinson's long enough and you really need to get every bit out of that dose, you're going to get more out of it by taking it away from meals. Usually taking it half an hour before your meal or 2 hours after a meal would give you the absolute most chance of absorbing every bit of it. And then we're kind of weighing between how important that difference is and how you can actually remember your medicines. So those are the factors that kind of go into it.
All right, I'm Catherine Price. I'm going to read a question here that's about deep brain stimulation and cognition. So, what research has been done into the cognitive risks of deep brain surgery? So that's actually a really excellent question. There have been quite a few studies here at UF as well as nationally and internationally about the cognitive risks of deep brain stimulation. And honestly, you should be pretty reassured that cognitive risks are very minimal. Of course, there's always a risk that was mentioned by Dr. Ramirez about the aspects of surgery in general with DBS for potential stroke and internal bleeding, but those are very, very rare. They happen infrequently. Cognitively after DBS, sometimes we'll see changes in voice volume. It's a little bit lower. You'll also see some changes in the frequency of pulling up new words. But in general, cognitively, people do very well. I see a lot of people post-surgery, and they do very well with regard to DBS. Okay, and there's what are the results and what are the considerations for people that have DBS surgery? So one consideration is the cognitive ability of the person before they go into the surgery. One concern is that individuals who are too cognitively impaired, do they truly benefit? And I think Dr. Ramirez did a really nice job explaining that they may not have a full quality of life improvement that the DBS is to target for individuals who are too cognitively impaired. So in general, I think of DBS as a different type of surgery than the other elective surgeries that have typically a lot of blood loss, and there's generally anesthetics used. So I hope that will answer your questions for that with regard to DBS. I have one other question. I'm going to move forward onto that. Okay. So this one is about dental surgery. What, if any, cognitive issues after dental procedures where nitrous oxide or twilight sedation is used? Again, that's a great question. Dental surgery, there have not been I don't know of any nice investigations with dental surgeries for individuals relative to cognition. But we do know that minor surgeries, nice studies that have been done, they're typically minor surgeries like cataract surgery, if there's like colonoscopy, those are typical surgeries that have not been shown to have any major cognitive complications. You always want to be aware of possible confusion that can happen. You want to have somebody with you afterwards to help drive you. So I would primarily talk to your dentist, identify what kind of anesthetic they're going to use, and then talk to your neurologist and hopefully develop some communication there, see what can be done to minimize the use of any type of pain medication or any type of sedation if possible.
Just to add to that, you shouldn't, it's not that you can't have pain control or appropriate sedation. I mean, you have to have it, find a reasonable balance, but of course, we want them to minimize it, not do it, extend it longer than necessary.
And that question is related to that, actually.
So I think this kind of goes along with what Dr. Price has been talking about, which it says, essentially, should a patient have general anesthesia or an epidural? And I think that the question is relating to if my surgeon is offering me something where I go to sleep or something where I'm awake, but they numb what they're going to work on, what should I pick? And I think that this is something that should be a conversation between the surgeon that's going to do the procedure. So you're going to ask, is there a safety difference, or is there, what do you think is best? And then you're going to talk it over with your neurologist to get some input there. Some people do just fine with either one, but I think if you can avoid general anesthesia, usually we would prefer that, unless it's going to be the safer way to go.
Oh, this is for
Hi. There's one question that refers to what covers the nickel-sized hole in the skull when DBS is completed. I should have mentioned that we don't leave the hole open. We cover it with something. Now, when you drill to make the size of the hole, you lose the bone, but you replace it with a specific cap. That's a plastic cap that has also a foam that kind of seals perfectly, and it completely seals the small hole that we do on the brain. So there's nothing, and you can barely see it. Obviously, if you're bald, you may be able to see it a little bit if you pay close attention, but Dr. Foot is very good at minimizing any of that.
So I'm Dr. McFarland. There's a lot of questions. These are wonderful questions from you guys. First of all, I just want to say, wonderful. Someone asked about, are we going to prescribe medical marijuana anytime soon here at the University of Florida? And I'll just say, this is an active discussion among physicians at the University of Florida, and the College of Medicine is still trying to figure out their position on this. And at the moment, we don't have anybody who really prescribes marijuana. It requires a special license, just sort of like pain physicians have to have a license to prescribe, especially narcotics, and that's in addition to the regular medication license. And so there's a training that needs to be done for prescribing marijuana at the moment. So currently in the neurology department, no one is licensed yet to prescribe marijuana. It's not that any of us are against it, but I just want you to let you know. There are online, if you do search, there is a statewide website, and there are physicians who are registered and able to prescribe marijuana for you. Again, we're not against it, and we do support it for certain uses, but again, as the talk this morning that was given, the current evidence we have for medical marijuana in Parkinson's disease doesn't really support its use directly for Parkinson's disease specifically. There are certain things that it does benefit patients for, for instance, intractable pain, severe spasticity of muscles. So there intractable epilepsy, where patients have refractory seizures. These are things where there is some demonstrated benefit for medical marijuana. So there are some things that can be treated specifically. So let me pass on, and we'll
just use this one. Oh, about the medical marijuana? Okay. So we'll move on to another question here. Just go to the top of my list. In your opinion, is there a neuroprotective benefit to starting an MAO, that's a monoamine oxidase inhibitor drug, long after being diagnosed with Parkinson's disease? So, for example, more than 10 years ago. and any comment on the new monoamine oxidase inhibitor that's been approved. So with regard to the new monoamine oxidase inhibitor that's been approved, it's called safinamide. It has been FDA approved now. In my opinion, there's not a lot of evidence that it's significantly different from the other MAOB inhibitors. So while I think it's great to have another tool in the armamentarium, I'm not particularly convinced that there's a dramatic difference between this one and the other ones. We'll hear, in case anyone else has a different opinion, feel free to mention when you answer your questions. And with regard to the neuroprotective benefit, so a lot of time and money was put into prior clinical trials to try to determine if there was the possibility of a neuroprotective benefit. And the design of the studies were in some ways criticized to say maybe the design of the studies caused us not to find a benefit if it was there. So my opinion is that the studies that have been done to date do not provide evidence that there is a neuroprotective benefit. What I will often do in many patients, if there's not a contraindication, I will start an MAOB inhibitor because it does have some degree of symptomatic benefit, and there is a possibility that down the line, new studies might support its use. But as far as studies that have been done to date, there are no studies that have ever definitively shown that it has a neuroprotective benefit.
On that line, University of Florida, we are currently doing a research study that is funded on one of those MAO inhibitors called Azilect or Visagiline. And the goal really for that study is to determine whether there are actually neuroprotective effects in the sense of can we prevent changes in loss of dopamine cells in the brain over time. And this is a MRI study that's over the course of a year. So we're actively pursuing studies to figure out and to determine can some of these drugs actually be indeed neuroprotective. It's a hard question to answer because we can't take your brains out and look at it. So we have to figure out other ways to do it. But if interested, that's a study that you all can participate in.
So, okay, thank you for the questions. Why are many of the studies so small? I imagine this is regarding marijuana. Well, you know, I think there's too many barriers there. One is a social barrier. I mean, the other one is a legal barrier. And the compromise that this led in scientists to test it in human beings. So I think that's one of the issues. Once it gets legalized, things will start to open finally. The other thing is that marijuana is not one substance. It's many substances. So we have to be sure with previous study in animal models that what we trying to use for a patient is safe enough to do studies. So for now, I know there is it's too much experience in the use of marijuana, of course. I mean, and it seems not to happen. But in terms of in a scientific point of view, I think it's the reason. The study that had more patients is not 21; it's 119 patients in Brazil. So we'll start to open on that. Okay.
I just want to mention, too, that we're all excited and optimistic about any new idea to help Parkinson's, but we also have to keep the caution side of it, too, that there are stuff in general conditions of marijuana that show it raises the chance of psychosis or it raises the chance of cognitive impairments or apathy, and all of those are things that we hope to avoid. So, you know, although we're optimistic, we also are cautious that we want to see, even if it did do something useful, would it be safe? And those are kind of the questions we all still have. And there's not good research yet to see, you know, will the cannabinoid oil be better and not cause those risks? But I guess we'll find out with time. Now that it's more accessible, there probably will be more studies to give us more to go on. Should we kind of start over again? Okay, I guess we'll just start down the line again and kind of go back through. So this is a good question. It sounds like a frustrated question. It says, please comment on the lack of commitment of hospital employees and doctors when you have Parkinson's disease medicines that must be given at precise times. This is for any inpatient. We are having to be very aggressive. Also, these same people must be told about meds we should not have. And the questioner was kind enough to loan her card with the things she carries around. And this is a really important question because unfortunately you think that doctors know about everything, but when you get into the nitty-gritty details of what works in the daily life of someone with Parkinson's, not all of them do. Not all nurses or doctors are aware of how intimately, how important is the timing of your medicine. So when you have a hospital situation, if you talk about real world, what happens, you've got one nurse with a whole bunch of patients to take care of, and what they're accustomed to are they have medicine giving times. They have medicine giving times that they go and administer medicines. And if you've got a blood pressure pill, whether you got it at 9 or 10 o'clock may not be all that important. But as many of you know, when it comes to levodopa, an hour could be dreadful, waiting an extra hour for some people with regard to their medicine. And so we're trying to do some education here, but even in a center like ours that has a lot of Parkinson experts, we've done studies that showed that there was a really poor job of honoring the timing and avoiding what we call contraindicated medicines, medicines that make your symptoms worse. We say you go in the hospital to get better, but sometimes you get worse. And so the National Parkinson Foundation has done lots of research and showed that 3 out of 4 times when people went in the hospital, they got something wrong. Either they messed up one of their medicines or they gave them something they shouldn't have. So the odds are very good of this kind of stuff happening. Some of you today, 30 or 40 of you, picked up an Aware and Care Kit. This is a little black pouch that's free from the National Parkinson Foundation, and in it is a card that you can keep in your wallet. And there's also a tear-off sheet of pages that say these are medicines that must be avoided and these are alternatives for Parkinson's. On the other side of that card or piece of paper says, I need my medicine on time every time, and it has the stamp of the National Parkinson Foundation so they don't just think, boy, this is a difficult person that's really demanding. So we're trying to educate them, but it's a slow process, and you're right, you do have to advocate for yourself. And those cards can be really helpful. If you don't have one, ask for one when you see us in clinic, or you can go on the National Parkinson Foundation website and order one.
Yeah, I think that going and speaking about that problem, it's a challenge with one of our patients or any patient with Parkinson's disease goes into the hospital. There are so many things that can go wrong and that can cause confusion, prolonged hospital stay, messing up with the medications, etc. It's really critical that we as doctors talk to our patients ahead of time. If there's any way that we can plan ahead, if a surgery is planned, to really develop a plan to try to minimize the number of complications that may occur in the hospital. It's very frustrating. It's very frustrating. I get very frustrated myself because sometimes you can bring the medications that you're taking that they don't have at that particular facility because they don't carry them in formulary, and they don't let patients take their own home medications. It just makes no sense. It's frustrating for the doctors as well. But I think that having a plan of action, having a specific list, and having an advocate right there with you could be quite helpful because it is challenging. I usually tell patients, especially when it comes down to confusion in the hospital, going to the hospital is almost like going back to college. You have a roommate, is always watching TV, they snore, there are people in and out all night long. It's just very hard. It's a very challenging environment, especially when you have more advanced Parkinson's disease. So planning ahead could be quite helpful. A couple more questions about DBS. There's a somewhat related question. There's a questions about what are the long-term, what's the future of DBS, and there's also some questions about newer batteries. So as I mentioned before, there's a lot of technology, new technology and new research looking at how can we use DBS to learn more about the brain? Can we use DBS in other conditions? And how can we make the technology better? So the goal and the future in DBS is try to identify better ways to deliver electricity through newer technology. So new companies are creating new ways to deliver electricity. There are new leads that have different contacts or that may allow the doctors to deliver more precise electricity to certain parts of the brain and minimizing side effects by stimulating other parts that we don't want. Battery life has greatly improved. Most of the companies, Medtronic has been around for many, many years, and they have a rechargeable battery. Some of the newer companies are also offering an option of newer batteries, longer batteries that would last 20 years or so. In general, depending on your needs or depending on the specific symptoms and the specific disease, most of the batteries that are not rechargeable last anywhere between 5 to 7 years, sometimes less. Like in cases of dystonia, sometimes the batteries, they are good for a couple of years. So a big push in technology has been developing better batteries, and the battery life, there are some companies suggesting that some of their devices may last over 20 years. We don't have enough long-term data because these companies are very new, but rechargeable devices are available, and newer, smarter technologies are coming. We're hoping that some of these developments are going to allow us to minimize side effects and improve benefit. There are not many studies looking and comparing these different technologies yet. It's very hard to do that, but we're also hoping to use the new technologies to learn more about the brain. There's so much that we need to learn to really figure it out. What are the best ways to deliver electricity and deliver the adequate control of the symptoms while minimizing side effects? How long does the battery? I think I covered that. Okay, I think. Oh, thank you. So there's a really good question here about, in our opinion, what are the considerations for early deep brain stimulation? Are you seeing any benefits? How are patients doing? And that's a very good question because a couple of years ago, there has been, over the past couple of years, new studies that show that the benefit from deep brain stimulation can be maximized if you intervene early. Deep brain stimulation was thought to be a last resource for many years. So what happened is that after 15, 20 years with Parkinson's disease, patients and doctors would finally say, well, I have nothing else to do. I have no other options. Now you go and think about deep brain stimulation. And unfortunately, if you follow that, the problem is that when you have had Parkinson's for so long, other symptoms beyond just the difficulties with mobility of the motor fluctuations take most of the central stage, and problems with memory, balance. The things that I mentioned, the leading source of disability are the ups and downs with your medications. You really want to get DBS when the effect of DBS is going to positively impact your everyday function or your symptoms. Over the past few years, people have been looking at younger or earlier and earlier patients, and there was a report that came from Europe that was published, I think, about 2 years ago, of a clinical trial that looked at doing DBS about 4 to 5 years of the disease onset. And people that have the classic symptoms that can benefit with DBS, but a little bit earlier stage. And they looked at quality of life, and they made an argument that say, well, if we can improve the quality of life early, we can actually deliver better care for some of our patients. Earlier is not always better, and the difficulties with identifying what's the best time to do the surgery, it really requires a lot of expertise. We don't have conclusive data showing that early is going to lead to a better outcomes long term. There's some initial studies looking at that, but you also have the concerns of requiring more surgery, and potential complications when you can manage some of the symptoms with medications. And sometimes also maybe operating in people that they didn't have Parkinson's disease. Sometimes you have to wait a little bit longer to really make the final diagnosis. So there's all these different things that make it difficult to decide when is the perfect time to do surgery. And I think that this, right now, at this point, having an open discussion with your doctor about your specific needs, it's the way way to go. We definitely want to use these technologies when we think that we can help patients the most, but we need to do it, short of not having additional data, we have to do it cautiously, because earlier, as I said, earlier is not always better. It has a variety of complications, and we really don't want to put patients through those surgeries if there are other things that we can do and try to maximize the overall treatment as a whole.
Very good. I've got a question from somebody about a drug called nilotinib, and I'm going to just ask really quickly, who's heard about this drug? Nilotinib. At least one? I expected more. Based on the flood of phone calls that we had when actually NPR did a quick story about an anecdote of a patient who described, I took this drug in a Georgetown University study. In fact, actually, the study was quite small. They studied approximately 12 patients who had Parkinson's, actually Parkinson's with dementia. And so the news story was that there were a few patients that gave anecdotal story that they had remarkable improvement in their thinking and their Parkinson's symptoms. And it was an incredible story. It was really quite moving. I actually listened to it on NPR myself on the way to work and realized, oh my gosh, we're going to get a flood of phone calls. And we actually were not prepared. In fact, the National Parkinson's Foundation was not prepared for the flood of phone calls of people asking, we want this drug because it makes people better. I'll take a step back and then I'll talk about the drug, but nilotinib is a drug that is actually FDA approved. It's not approved for Parkinson's disease, it's approved for treatment of leukemia, cancer, blood cancer essentially. It's a chemotherapeutic agent. And it's a good example of actually looking for new drugs that might actually help Parkinson's disease. And as you all probably know, the time for going from a lab to developing a drug and getting it, studied in a disease and out there can take 10 and actually closer to 20 years sometimes to be studied and approved. So actually one way for us to look at drugs is we have an enormous store of drugs that are already approved by the Federal Drug Administration. So one way is actually for us to go and look at drugs that are already approved. And a couple good examples that are like isradipine, that's a blood pressure pill that's already approved. And there have been some studies as to whether that could be helpful for Parkinson's disease. Another one's a diabetic drug called pegloticone. So a number of drugs out there that they don't have to go through FDA approval or time. So why don't we go through our tens of thousands of drugs we've got on the armamentarium already and see if any of these actually will help Parkinson's disease. So that's in fact what's happened over the years. And so some of these, we get positive hits from time to time, and nilotinib was one of them. There actually were a number of animal studies that looked at this drug, and so there's a molecular pathway that seems to be affected by nilotinib that may actually reduce what's called the load of protein called alpha-synuclein and maybe even save dopamine cells in the brain. And those are the ones that we want to save in Parkinson's disease. So the idea is that perhaps this drug could be what's called neuroprotective and help patients. And so there's pretty good data on it. And Georgetown University did some of those initial studies. And they went ahead and, since they were successful, they went ahead and they did what's called an open label study on a number of patients. Open label means basically you know what you're getting. It's not blinded. And I think there's an important difference between those kind of studies and what are called randomized, double-blinded type studies. We know these days that in patients who have disorders that don't have cures progressively get worse over time, and you've been waiting for a long time for that golden ticket, that one drug that's going to cure this disease. People have high hopes, and none of us blame you. We have high hopes for everything we're doing. So there is a lot of bias, and when people take medications, there can be a mind over matter kind of thing. We call it the placebo type effect, where we give you a sugar pill versus another pill, and it turns out the sugar pill works just as well as the actual drug that we're giving you. So if you believe in something enough, it really can have a true effect. And so doing open label trials are a lot of ways biased that way. It's not that this drug, nilotinib, which was studied that way initially, may or may not have effect. We're not placing judgment on it, but it's number one is an open label that limits our ability to make really any direct conclusions about the study. It's also really very small, okay? And the effects so far have been mostly we call anecdotal. So I want to warn you about that. We are excited by any new drug like this that's already approved and has been studied. It's been demonstrated to be relatively safe in most patients. But without further study, it's not a drug that we can actually recommend for Parkinson's disease patients or dementia patients or other disorders because it just hasn't been studied enough. We don't know what its safety profile would be in you all. So from our standpoint, physicians, I think we're emphasizing the same thing that Dr. Malati was saying. We want to be safe. As physicians, our motto really is do no harm. We don't want to make you worse. So what we are really is waiting for a clinical trial that will study this drug. And actually there are other drugs that are related and similar in function to nilotinib that actually might be better and safer that are coming out. So we're waiting for the next trial. If a trial comes down our pipeline, we will probably be calling on you all to try this out. But we'd like to do it in a controlled fashion so that the actual results are meaningful and will change how we treat Parkinson's patients for the future, for the better and hopefully not for the worse. So we're being cautious. So that's the information about nilotinib and other drugs. Interesting question. Thanks.
So the next question, I have two somewhat related questions here. I'm going to try to answer them at the same time. First question is it common for patients with Parkinson's disease to lose the ability to play the piano? The questioner is noting that they can't play music they used to know from memory. So this is a really interesting question because there are a host of motor symptoms of Parkinson's disease that are not really talked about very well and that don't respond very well to the medications that we use. So everyone knows what the classic cardinal symptoms of Parkinson's disease are. Many patients get a resting tremor, there's rigidity, there's slowness, but on top of this, there are other more subtle symptoms of Parkinson's disease. One of the things that we notice is patients get what is called a limb kinetic apraxia. So patients will notice, especially with distal limbs, like in the fingers, they'll have difficulty individuating movements and making the individual fingers work together. Now, what's interesting about this, those of you who've had difficulty with fine dexterous movements of your fingers, you'll notice that you'll have an off period, you'll take your medications, you'll clearly feel on, but fine dexterous movements don't tend to get better. So this is something that a lot of people notice, and it's something that often can give rise to things like having more difficulty playing the piano. Another thing that's not as often appreciated is a phenomenon called dysrhythmokinesia. So patients with Parkinson's disease have a harder time maintaining a rhythm. And interestingly, if it's a slow rhythm, patients with Parkinson's go faster than they need to. They make errors leaning towards going faster if it's less than 3 times per second. If it's faster than that, then they tend to go slower. So that's another reason why someone who used to play the piano very well might notice that that skill starts to deteriorate. Another very common aspect of Parkinson's disease that's not really discussed as part of the cardinal symptoms is a loss of automaticity. So we all do movements that don't require our attention and that we're able to do while doing other things. So this is something that deteriorates as well in patients with Parkinson's disease. I'm sure just about all of you who are patients in the room have noticed that your ability to do 2 things at once as soon as you're diagnosed with Parkinson's disease really deteriorates. And that's why we often recommend that if you have tasks to do, make sure that you address them serially rather than in parallel, because you will notice an impairment in your skills. Even if it's just something like trying to figure out their directions and driving at the same time, that might be something that would have been simple for you 10 years ago or 15 years ago, and it can be very, very troubling now. So with regard to what could cause that type of thing, difficulty playing the piano, limb kinetic apraxia, this difficulty individuating and combining finger movements, loss of automaticity and dysrhythmia would be the biggest things that would give rise to it. Along the same lines, someone wrote that. Oh, sure.
Can I hop in on that real quickly? So to add in from an occupational therapy standpoint, we didn't get to talk about that, but with the limb apraxia, I talk about, I kind of call it a taco hand, right? The Parkinson's, it becomes rigid, it kind of sits in this resting position. It likes to hang out here. And the Parkinson's hand kind of likes to work as a unit and not individual fingers, right? So you'll notice when you go to do something, you try to go and all the fingers work, right? So sometimes you'll feel it feels clumsy and it doesn't work well together, and that's that limb apraxia. And there's lots of things that we can do in occupational therapy to help with that. But one of the things that we talked about in the OT lecture was the high amplitude movements. And I was going to show you a video of high amplitude hand flicks. And I know some of you guys do these in your exercise classes, but just with your hands empty right now, I want you to try this with me, okay? So you're going to make a tight fist. And what you're going to do is you're going to open them up as wide as you can go. Now, I don't want anything small. I want it big as you can go, so you feel kind of like a burn across, like a stretch burn across these fingers. And I want you to make sure you get a nice wide finger. So look at mine and look at yours, make sure they're wide. And then tighten them again, and then big flick them, all right? I want you to do that 10 times before you do any fine motor activity. So that could be piano, handwriting, toothbrushing, you name it. And I want you to do that 10 times. What that does is that gets those joints, get that proprioceptive feedback. And what that means, it just kind of tells your joints where it is in space. You'll notice after you do that 10 times, your hands might feel a little bit of a tingle. It's not a bad tingle, but it just kind of wakes up your joints and says, hey, here's where I'm at. Now I'm better able to function. And it doesn't rest in this position as much, so your fingers move a little bit better.
That's great.
So I'll address the other question really quickly. I was diagnosed 5 years ago. Recently, I have been dropping things. Is this common, and is it possibly age-related? Typically, dropping objects is not something that's age-related. It is not uncommon in Parkinson's disease. There's a number of different things that can give rise to it. Assuming that the dropping of objects is occurring without a loss of consciousness, where someone stays awake and they're not having episodes that could be more complicated, there's a couple of things that go on in patients who have Parkinson's disease. In some patients, you can get neuropathy, and the feedback that you're getting from your fingers is not quite fully intact. So that can sometimes give rise to dropping in some patients. In other patients, both Parkinson's disease itself and the medication for Parkinson's disease can give rise to small movements called myoclonus. Sometimes these movements are very quick, brief, fast movements. Sometimes they are quick, brief, and fast loss of muscle tone. So sometimes patients who have myoclonus will notice dropping of objects. The neuropathy symptoms are not unusual. They're more unusual in the hands. So most of the time when people notice a problem with dropping objects of the hands, the problem is one of controlling force. So one thing that Parkinson's disease patients have, in addition to, along the same lines, the cardinal symptoms of the disease, is controlling force. So if you're holding an object, you have to maintain a force that's going to prevent that object from falling due to the force of gravity, but yet at the same time not be too hard to where you're going to damage the object in some way. So it's not unusual for Parkinson's patients to miscalculate that, and they'll often hold objects too weakly and the objects will fall. So not age-related, but not uncommon in Parkinson's disease.
Okay, another question is spelled Mucuna, Mucuna pruriens. This is the herb come from the Indian alternative therapies. M-U-C-U-N-A. Pruriens mean itching in Latin, so you can change it that. The fruit where the seed comes from is a large fruit, hairy fruit that produce itching. That's why they take the name of that kind of the plant. So it's Mucuna pruriens. The other question inside this one too is B12 is helpful. Of course, it's helpful. I mean, in Parkinson's disease, it seems that B12 have low levels. Patients with Parkinson's would have lower levels of B12, and the explanations for that are complex. But one of the things that could happen because you have, or a patient has B12 deficiency is neuropathy, trying to what Dr. Hess was explaining. So there is some studies that could mention that levodopa treatment could interact in the absorption of B12 medicine, and could be a reason for that, the interaction with levodopa in the GI and the B12. The one that I mentioned that could be helpful for avoid risk of Parkinson's is V6. B6 is the other one. So. That's it. Okay.
So I just wanted to add to the, I don't know, those of you who want to try Mucuna, it's a wonderful herbal, type of therapy, but I do, the preparations you get, sometimes there's the Mucuna extract, and it's over the counter. Understand, so those of you who want to try it, it can be tried. We're not against it at all, but I do want to just caution folks about it. It's not really regulated. You don't know what you're getting over the counter. So the amount of what's called levodopa that really will help your Parkinson's disease, it can be important for many of you. And there's a dose of medicine that you're getting on a regular basis. Some of you need it, every few hours, and that dose matters. And what you're getting in Mucuna could be much lower, and you don't know what you're getting. So I want to caution those who do want to try it. Please do talk to your neurologist, talk to us about it before actually deciding to just go ahead and try it and use it, or even, for heaven's sake, just replace what you're taking currently, because it really could make your symptoms potentially worse. Okay.
So these two questions are kind of together. One of them is, will there be a nutritionist available to help patients manage required protein intake and also patients in danger of weight loss? And the other question is, how well a person's stomach work affect how well their medication will work, how well their stomach works. So the first part is, we don't currently have a nutritionist on hand. There's certainly been a lot of interest in that, and it's something in the back of our minds that would be nice. You can get referred to a dietitian, but not necessarily at our center. For most people, a balanced diet is the way to go. There's not a specific diet. And then for some people, noticing the timing of medicine with eating can be an issue. Weight loss is a very common part of Parkinson's the longer people have it. So the comment included the danger of weight loss. And there have been a lot of theories about why that is. One of the theories is, well, maybe when people have tremor or dyskinesia, maybe they burn more calories, or maybe people are eating less. And different little studies have tried to look at calorie counts and how much is expended, and nothing's really been able to clearly explain it. So there are some metabolic changes where this commonly happens, and people may lose 10 or 20 pounds without trying. So, talk with your doctor. Sometimes that can affect how strong your medicine is for you if you have a major weight loss, and it does require kind of looking at how much you can eat at a time. That transitions into the second question about the stomach working. So the intestines in Parkinson's can move more slowly. So people can have something called gastroparesis, which is delayed digestion, and sometimes it's common to have constipation. Constipation is common many times, even before people have any obvious signs of Parkinson's. That's the mildest end, is constipation, and the most severe can even be gastric obstructions from not moving well enough. And so sometimes that involves working with a gastroenterologist. There is a study that can be done called a gastric emptying study, where you go and consume some food with a tracer, and a picture is taken at 1 hour, 2 hours, and 4 hours later that can detect how much is left in the stomach compared to what should be. And if your intestines are not moving properly, it can affect how consistently you absorb your medicine. It may take too long to get your medicine absorbed, and then other times you get too much at once. So it can actually be really important to how someone with Parkinson's does. The other tricky thing is that one of the most common medicines that can be used for gastroparesis is really bad for Parkinson's, Reglan or metoclopramide. So really need to have your neurologist involved in the conversation and how to manage that problem. Some people find that they can only eat a smaller amount at a given time because they get full more easily. And so the weight loss and the intestinal movement tie together, and sometimes you have to learn about what foods are calorie dense. That means more calories with less volume of food. So things like nuts or things that have more nutrition in a smaller amount, and maybe eating more frequently. So there are different tricks. We can give you some advice on the matter, and then we could always put in a referral for either a gastroenterologist or nutritionist, depending on the situation.
Okay. Quick question. Do you see atrophy of hand muscles in addition to hand tremor in Parkinson's disease? So Parkinson's disease itself does not specifically cause atrophy of hand muscles. Typically, atrophy of hand muscles can be due to a pinching of a nerve, or it's usually due to a neuropathic symptom. Often it doesn't have anything to do with the Parkinson's disease, and very often it can be due to a spinal condition that doesn't particularly need to be addressed, or addressing it would cause more problems than it specifically would fix, or it might be high risk. So the answer in general is you don't see atrophy. It could be something else. Depending on the severity of weakness, that's what it would help to allow you to decide if it's something that needs to be addressed. Another question, if you're experiencing occasional once-a-week off symptoms after taking medications, is this a sign of body tolerance to the medication, or is this a sign of other agitating factors, such as a bad mood, getting in an argument, as the cause? So typically, people wear off when the medicine reaches a level in the bloodstream to where it's no longer able to provide a level of dopamine to normalize the symptoms in the brain. Your body never gets tolerant to levodopa. What usually is the case when someone's experiencing off phenomenon, but it's only happening 1 or 2 times a week, is there's a huge degree of variability that happens throughout your day with regard to your emotional symptoms, with regard to how much sleep you get, with regard to how much food you eat and what type of food you eat, and then the timing of taking your medications compared to the food. So typically, when you have those types of symptoms that are occurring only once or twice a week, it tends to be just variability in your daily activities. Sometimes you can identify what it is, especially if you keep what's called a Parkinson's diary, but it's not a tolerance to the medication to make you think that you're going to need more in any time in the near future because of that symptom. Just about everybody over time will require more levodopa, but it's because the disease progresses, not because tolerance develops.
Okay. I think this question could fit also with the one that answered Dr. Malati. How does sugar affect Parkinson's disease? One thing is the risk, and the other thing is what is happening when a patient have a condition. So the risk for Parkinson's, it seems that is related with the amount of calories. There is a couple of studies that shows that subjects that take lower calories a day could have decreased risk for Parkinson's. And as I told you before, it's only a couple of studies, so we don't know. But once you get Parkinson's, you have to be in a good condition and have a very good nutrition for confront your disease. The other one is about barbecue as a cause of Parkinson's. There is a study on byproducts, and it seems that especially meat as barbecue could have liberate some substances that could be related with a risk for Parkinson's, but it's not a cause. So we have a very few information on this, but we have something there. And the last is about alternative medicine in acupuncture. It is acupuncture of value in treating Parkinson's disease. I think there is a couple of studies on that, and it seems to be helpful, relaxing, over pain, and even for some motor symptoms, so it could be helpful. I don't know if I will recommend specifically to go with someone to do it, but it seems at least it's not nauseous. No?
All right, one last question, so we won't keep you too much longer. You guys have been really wonderful. These questions are fantastic, by the way. And I know if we stood here, we could probably take thousands more questions. But this one's about Parkinson's disease in clusters. I think we heard this in another group, at least 3 people in a similar area. I just give you a short answer, really. First of all, Parkinson's disease is fairly common. I guess one could say it could be coincidental, but it does raise the question, really, are there potentially some environmental factors that are a cause of Parkinson's disease? This has been a question that has raised numerous different studies, and it's a difficult question to actually answer. These are what are called epidemiological studies. Essentially, the question really is, there are many toxins that have been associated with Parkinson's disease that are in the environment, either pesticides, herbicides, things like things that are in gas, benzene, toluenes. There are lots of things, metals, heavy metals. Several of them have been kind of all associated with Parkinson's or developing Parkinson's, not necessarily Parkinson's disease, but Parkinson's-like symptoms. So the answer is yes, we do know a number of things that are actually out there, but it's hard to judge exposure in a lot of individuals. So when did it happen? How long did it happen? Meaning how long were you exposed? For instance, if you think you were exposed to pesticides, were you on a farm? Were you a farmer? Were you a migrant worker that was on a farm that worked with those toxins for a decade long? And when did that happen? Did that happen 30 years ago? And how do we prove that that actually led to your Parkinson's? Those are difficult questions to answer. But the short answer right now is yes, we know several toxins, and there are sometimes these clusters, but we don't exactly know what the identification is. Certainly, I think the $64 million question really is what causes Parkinson's disease. And I think at this moment we know there are a lot of different causes, both genetics and probably environmental factors. I like to say that the genes kind of are the gun, they kind of cock the gun for you, and maybe there's some stress or environmental factor that fires the gun off sometime later in life. But that's a very simplified way of viewing it. We are still actively working on this particular question. But thank you for this. It's a great question.